so we're going to talk about reference frames, and we're going to limit it to lumbar reference frames today. So there's a number of different strategies that you can use, and actually we're going to venture into the thoracic spine also. I'm probably not quite prepared enough to do a great presentation on cervical, which is a whole different one, because we do anterior, we do posterior. So with that being said, I'm going to show you a couple of different things. We have some MIS ways we do this. We have some open ways we do it. We also have some revision ways that we can do it. And as I said, I'll show you some thoracolumbar junction strategies, what you can use. I'm going to start with one which I actually consider the least favorite of mine or least used, but it's certainly one that I use on occasion. I've done it a couple times just in the past month, so I shouldn't poo-poo it too much. But this is the Pelvic Perc Pin, and what it is, it's driven into the iliac crest and across, and you can put it across the cortices of the sacroiliac joint to get more strength. We have a little tiny pilot hole we drilled in here, but we do this through a single stab wound. So this is truly a minimally invasive guidance technique and putting your reference frame on. So everything that you think about whenever you put a reference frame on to do some kind of navigation is that you need to think about where you're going to be doing the operation, because obviously you don't want to put this thing in the way, okay? So just planning or thinking about it, that if you're going to put in some L5 pedicle screws, I think you can see this. Now go back to the live, thank you. So everything's out of the way, right? We're going to put in an S1 pedicle screw. Here you go. Where's Dr. Chapman? I'm not using navigation, but I'll bet you I could put these screws in. So, sorry, Jens. So anyway, that's a good position, a good location. It's pretty simple. You do it through a stab incision, and you put it in. As I said, across a couple of cortices. That's a pretty strong device. Okay, I'm happy with that. You just have to be wary of it, and you just have to not be bumping into it, leaning on it, and other things like that. And you can change the position of some of these where you can turn it around and face it different directions. You probably would end up putting your camera system off to the foot of the table. This is head up here, here's the sacrum. That would give you navigation in every direction for every one of these things that you want to do. So it's not going to be in the way. Here's your sacral screws. Here's your pelvic bolts if you want to put those in. Okay, so that's all pretty straightforward. That's the simplest, least invasive way to do it. We can pull this out, and we're going to move on. Okay, so we're going to do mini open. Here's your standard, real basic reference frame. You're going to put it on a spinous process. We will do these when we do our MIS cases, just because we make three incisions, and they're all three about the same size. If we can put in 6 pedicle screws at L4, 5, L5, and S1 through Wiltse approaches, and we do those through incisions. I don't know if you can see it here, but when you're dealing with a patient here, you got pedicle screw, pedicle screw, pedicle screw. So the convergence of those 3 screws is going to give you an incision where Wiltse's on both sides like that. So a little tiny midline incision over a spinous process, and it doesn't matter what spinous process you put it on. So that's a very rigid, very robust device. You can see that it does flex a little bit, pretty much real life, the way it would with a bone. It will flex that much, but we try not to bump anything. Okay, so we're going to move on from that one. Screwdriver, here we go. Now, when we're doing open revision cases, okay, if somebody has a L4 and we're going to extend it up, and so we open the patient, everything's been opened up, which you see here, and you got big retractors in. We pulled all the hardware out, we're putting new screws in, and actually we do a check spin with our CT scan after we put all the hardware in, and then we use what's called a J-frame, and this is a homemade J-frame. There you go, I'll put it down here. That's a homemade, it's just a rod, that's all it is. And you put it in 2 screws. So this is actually the simplest thing to do. It's way out of the way that if you're gonna, got a couple of caps, please. There you go, thank you. So these are just simple. They're incredibly, there we go, incredibly strong. There you go, thank you. Incredibly strong. And this is just your strategy for doing revisions, big open revisions. And there's actually a custom-made one, but I've done this before, is that you actually just use this thing and you can clamp it right on. Where's the T-handle? There we go. And you can clamp it right onto a rod. So we made these at home for quite a while, and then I guess I didn't patent this thing. I should have. Now they come if you ask for it. So there you go. Incredibly robust. This, you have to think about it also. Where are you going to be for doing a revision, okay? If you don't like where, where this is, if you're going to add screws all the way up and you're going to extend an existing fusion, depends what you're doing, you got to think about it, because this is not going to work right here if you're going to be putting pedicle screws in the upper lumbar spine. So you say, okay, good. You got to think. There's a little bit of thinking to this. You say, I'm going to put it in a different location. I'll put it down below. It's easily done. If you got your camera down below, that makes more sense. If you have your camera up above, you can turn your reference frame that direction, then you can do your CT scan. So that's assuming everything's done here and you've got all your checks, check your position of all your hardware. Okay, and then you can do anything further up north, cephalad out of that, and it's out of the way. Obviously, there are some things about line of sight distance. If you have this thing too far away, I mean, the closer you are, more preferable for everything. But, you know, this is pretty darn robust and things do move. So there are different size J-frames that you can have that rather than my homemade device here. So that works as well. Okay, so we'll move on to T-clamp. There you go. Where I got that. Let's take this one off. And what do you do if you're going to do something in a lateral position, like through the chest? Is that thoracolumbar junction, and I showed you all kinds of endoscopy things today. But what I do for thoracolumbar junction, if I'm going to do a decompression for a thoracic disc at T10 or below, I will put a reference frame on a spinous process after the patient's positioned in a lateral position. Okay, so I'm doing this kind of right now and I'm pre-positioning it, but we do this after we put the patient in a lateral position. I think maybe for Let's Reality, let's do that just for the heck of it. How about that's a little fun. So after a patient's turned into a lateral position, you can do this for lateral navigated cases as well. Okay, you reposition the cameras here. John, I'll get you to help do this. So we're going to reposition the patient here. If you want to put it on, clamp it there. We will, in a lateral position, after we get positioned, so we can do lumbar delift cases. I don't do a lot of those navigated. I still do. That's probably the only case that I do with some regularity is fluoro. But if this was a thoracolumbar junction herniated disc, and I'm going to go through the chest. We got the camera over here? Okay. That if I'm going to go through the chest somewhere in this location, okay, actually here's the angle. We're going to go along a rib. This is where I'll use a reference frame and we'll have a CT scan. So have the camera up at the head of the bed. That's where you do it. We can turn this, John, if you can do that. Rotate that around. Okay. Go the other way. Go the other way. So if we have the camera at the head of the bed, we can see there's going to be one surgeon who's going to stand over there. If I'm the surgeon, I usually want to stand on this side and the front side of the patient, so we have them in a position. So even if I lean on them, we move around, we rotate the bed. Some of my partners get a little worried about moving the patient on the table, but once you have it clamped to a spinous process that is pretty close to the thoracolumbar junction, you're pretty darn close to do decompression surgery. I don't do many fusions in thoracic disc surgery, very few. But you can navigate those. I have a video I didn't show today, but that's another one you can do as well. So we're not going to do the cervical one. So that gets us through there. Are there any questions for us, Amir?
Any questions from the crowd? I did have a question. You know, if you're doing this lateral, sort of, for instance, you're doing a thoracic disc, and you know, I always worry about in the lateral my patient moving around. Do you find that creates a lot of interference on your image guidance?
For navigation, surprisingly not. We tape the patients down to the bed, put them in a lateral position, and I think one of the things, and it's one of the things that I think using tape to position a patient is critical for a lot of things, and that's one that I'm not talking about it, but I guess I can a little bit, is that when you use a Mayfield head holder and you have the patient either on a regular Skytron bed or on a Jackson table, we use tape. Tape helps us a lot. One of our old fellows, our residents who was a fellow here, he actually really got us keyed into reducing the motion. So if you put tape over a patient, you have to have tape on a little bit of the skin. Obviously, you don't want it on all the skin, otherwise you get skin burns. But you get a patient in a lateral position, you put plenty of tape down across the chest and across the hips. They don't move very much. And also the spinous process clamp is pretty robust. You put it as close to where you would guess the thoracolumbar junction is. The thing about navigation is usually if you have a calcified disc, that's your localization, so you don't have to worry about localization, have your reference frame in the way. So the motion is so little, it's pretty negligible. So I'm really comfortable doing it. I do a lot of thoracic disc surgery, and it's really about the patient being taped down to the table is the most important thing, and put them in a true lateral position, get them out to the edge of the table, just like I'm showing here.
Great, thank you. And I guess another question about those thoracic discs, how do you feel like you've gotten enough if you're in this position and you want to get a good decompression there, calcific disc? I know for the most part when we do them all posterior. It's quite an invasive procedure.
Well, it's a great one. I'm glad you asked that question. I wish I could give that whole lecture. I got a whole bunch of PowerPoints that I give a talk specifically about that. But thoracic discs, at the thoracolumbar junction, I actually do most of them with a mini open procedure. And I'll put the patient in position, lateral, just like this. We'll put the reference frame on, and then I will actually localize the incision with the navigation. And I have a chest surgeon open them. Can we see right here? I don't know if we can move the camera a little bit, or maybe here, I'll move the, okay, so.
Yeah, we can see it.
5, 4, 3, 2, 1. If I'm doing something up at 10 or 11, I just did a couple of them recently like this. So we do a thoracotomy. I call it a little boutique thoracotomy. Okay, so the thoracotomy is localized directly lateral to the spinal column at the level that you want to operate on. That's so you don't end up with an incision that's above or below and you're working in some odd angle. That is so critical, that if you don't get a perfectly perpendicular view to the long axis of the spine and you're centered right over it, so when you open up and you're down at the, looking at the diaphragm at the costophrenic angle, and you have the chest surgeon open up, and I usually do most of the opening after he opens the chest. I just go in and I'll reflect the diaphragm a little bit if we're down that low. And so it's having that direct lateral approach, having the navigation. The decompression part, actually I love these operations, they're some of the fun ones, is that it's basically boring a hole underneath, okay, that if, let's point here, okay? Can we do it on the, let's just pretend. Can we do that? Can we navigate this one too? Yeah. Okay, let's bring them all up here. We got a minute here? You want me to walk through this?
Yeah, please go ahead.
Okay, all right. So let's pretend this is a T10, okay?
Is there any way we can get the
We're going to get navigation here.
Great.
Yeah, we're going to get the navigation here. So we got a straight lateral. We're looking in. We made a thoracotomy here, and we're looking straight down, but you're looking at pleura, right? You can't see anything. Mm-hmm. You're just looking at pleura. So it's a virtual dissection in some respects. Okay, are we here? Is that working? Okay. So what do we got that's like, okay, just pretend this is a drill. So I go down and I find the disc. We can usually find a rib head. How do you want to turn it? Just turn this way. There you go, thank you. Okay. So in the thoracic spine, usually the rib head above will point directly at the disc space. Okay, and if we're doing it thoracoscopically, we got to drill off the rib head, and then you're looking at the pedicle, and basically after you remove the rib head, you take a little bit of the inferior pedicle off, and what you're doing with a thoracoscopic or an open discectomy, in my view, is that you're boring a hole and you're creating a big cavity underneath, and it's not that big. It's really not big at all. You're boring underneath across the disc space, and we'll see this pretty picture. We'll see bone, cancellous bone, disc. We cross the disc, and we drill into the vertebral body, so it's a little bit of a posterior vertebrectomy, and we take out the back 1/4 to 1/3 of the vertebral body, and we go all the way across the spinal canal. Now, let's see if we can see it on the nav if I just poke this through the disc. I don't know how well that shows.
Yeah,
There you go. We're going all the way across. So we go all the way across, okay? It depends, you just look at your preoperative CT scan and you figure out where you are. Let me get this, we have some bone anatomy here. There you go. So here's my surgical trajectory, right here, all the way across. And I navigate the drill all the way across. So I am undermining, creating what I call jokingly a garbage can underneath the spinal canal. Undermine the whole thing, straight across, vertebra below, vertebra above. Take out the intervening disc in between, which has it's just creating an entry because the herniated disc is up in this location.
Yeah.
Right? And that's where the business is, right? So you're basically just creating a big resection cavity that we can work in. Then when I've gone all the way across to the other side, okay, and I can navigate it right to the other pedicle. That's what's beautiful about it. I do this whole thing with a large cutting bit. I use a Midas bit, a 33 cutting bit, and I navigate the drill. I use a Midas R or TU bit, big long one that's like a foot long. It's a big weapon, and I use it with 2 hands. So I go across and resect this whole area all the way across underneath. And actually, about 80 or 90%, probably 80% of the entire disc is left intact. And I never say never, but I almost never do a fusion in the upper and mid-thoracic spine. Almost never. Wow. I don't think you need to, because we go in and after this decompression is done, we're going to go back to the edge. We'll find the PLL. I'll go on the other side. I'll go into the foramen. I'll find the lateral dura right here. And I pull the disc down and we cut across the ligament and a big piece of disc comes out.
So you're actually directly seeing that herniation come out?
Absolutely.
Okay.
And I see the billowing dura when we're done.
Yep.
Total complete decompression. It's extremely gratifying operation to do and know that you've done it. And it really is a minimally invasive way to do it. And not doing a fusion. In fact, I got to write that up because I've done probably a couple hundred of them with no fusion, and they do great.